last but not least for this week, chapter 29, which talks about atherosclerosis and cholesterol medications. So we've talked a lot about already about the buildup of fatty plaques within the arteries. And this is a process that starts in childhood, as early as childhood, depending on our diet. So atherosclerosis is a progressive condition that leads to coronary artery disease and peripheral artery disease. It is the leading cause of death and illness in the United States. And it's a disease that begins again in early childhood or early adulthood, in which fat builds up in the smooth lining of the arteries. This accumulated fat, called plaque, is mostly cholesterol with calcium, cell debris, and other substances found in the blood. Cholesterol is a critical substrate for the body. Our body does need it, and our liver will make it. It's the fundamental building block of steroid hormones, which we've talked about how important those are. It's essential for building cell membranes, myelin sheaths around nerves, and essential for building up the brain cells. It's also the core component of bile salts, which helps digest dietary fats. So cholesterol is made up of lipoproteins. There's several different types. You might have heard of good cholesterol and bad cholesterol. Good cholesterol is HDL, high density lipoprotein. Bad cholesterol is low density and very low density lipoprotein. That's about as deep as I want to get into that. I don't want you guys diving too deep into this, sort of breakdown of LDL, VLDL. I just want you to sort of understand the different types that are out there. Bouncing back, I think I skipped a slide. Atherosclerosis, there are two different types of plaque buildup. Stable plaque is, it hardens the cell wall along the vascular smooth muscle and pushes into the space where blood flows through in the artery, so it can reduce blood flow and oxygen supply to the blood tissues. Unstable plaque also is a buildup, however, it has a thin cap, so it can erode, rupture, and break away. The ruptured material is called a clot, and it can travel, or a thrombus, and it can travel through the bloodstream and completely block a vessel. When blockage occurs, we've talked about arrhythmias, we've talked about heart attacks, we've talked about chest pain. It can also cause strokes as well as pulmonary emboli and deep vein thrombosis. So this is when we start to get nervous that we are going to irreversibly damage a patient with a clot. So we always want to be on the lookout for that. And those medications that we talked about in the last chapter were important for treating, preventing those clots. So moving back forward, cholesterol also consists of triglycerides, which are the main form of fat from diet regardless of the source. The body converts any calories it doesn't need right away into triglycerides and stores them in fat cells. Triglycerides provide your body with energy, however, too much of anything is not a good thing. So, monitoring for risk factors for atherosclerosis. Risk increases with age, with smoking, high blood pressure, premature menopause, overweight people, diabetes, and hyperthyroidism. Usually we recommend lifestyle changes right off the bat for people, which mostly includes diet and exercise, and of course stopping smoking. Goals of treatment are always lowering LDL cholesterol, reducing total serum cholesterol and triglycerides, and increasing our good cholesterol, which is our HDL. There are 5 classes of drugs used to treat hyperlipidemia, which is high cholesterol. HMG-CoA reductase inhibitors, cholesterol absorption inhibitors, bile acid sequestrants, fibric acid derivatives, and nicotinic acid. So let's start off with our statins, which are our HMG-CoA reductase inhibitors. So a very early step in the conversion of cholesterol is uses HMG-CoA, which is a type of enzyme. So if we can inhibit that, we can prevent cholesterol from being created and stored, and thus reduce our levels. This is in addition to dietary treatment and exercise. So that's about as much as I want you to remember about that. Statins are the most widely prescribed anti-cholesterol medication. Adverse effects include headache, dizziness, alteration of taste, insomnia, abdominal cramping, and photosensitivity. It may also cause muscle pain, leg aches, and muscle weakness, and they are never taken during pregnancy because they can interfere with the baby's ability to synthesize lipids. So one of the big things we watch out for, it's rare but serious, would be muscle pain, something called rhabdomyolysis. If the patient experiences this, they have to be stopped on the medication immediately, and we no longer let them continue. We can try them on a different statin, but generally we stop the one that they've been on. Our next class, cholesterol absorption inhibitors. These block the absorption of cholesterol in the intestines, and the one in this class is ezetimibe or Zetia. It decreases very low density lipoproteins and also decreases circulating LDL. It's indicated in the treatment of hyperlipidemia in conjunction with diet alteration, and it's also in combination medications because it's synergistic with statins, so you will see it in combination medications. So adverse effects of ezetimibe include abdominal pain, fatigue, coughing, diarrhea, back pain, and arthralgia. And it's usually given once a day, which is a good thing because we don't want to give it more than once a day. It's inconvenient for the patient to have to take a medication more than once a day. Our next class, bile acid sequestrants. Exactly what it sounds like. It binds up bile salts and cholesterol in the GI tract, which prevents absorption of both, and it's used in hyperlipidemia. Adverse effects, of course, include GI disturbances because it's not systemically absorbed. It's just going to cause problems in the GI tract, such as constipation, fecal impaction, intestinal obstruction. So our next class, nicotinic acid. Niacin is the major medication in this class, and it affects cholesterol synthesis through a G protein coupled receptor. So it inhibits triglyceride lipase, and it decreases free fatty acid release and removes triglycerides. So it's really good for getting triglyceride levels down, and again, it will be used in combination with other medications. Adverse effects, the most serious one that we see is flushing, which isn't so much serious as it is bothersome to the patient. Vomiting and diarrhea as well. Our next class is fibric acid derivatives, which is gemfibrozil and fenofibrate. It inhibits the breakdown of fat into triglycerides and limits liver production of triglycerides. And it's, again, focusing on triglycerides, so that's when we would use that medication. Adverse effects include nausea, vomiting, diarrhea, and gas. And on, just as in your book, on slide 19 has a comparison of the hypolipidemic drugs. Preferred therapy. They're all indicated for reducing cholesterol levels. As you notice, some of them focus on triglycerides. Our statins are mostly for LDL and triglyceride reduction. And they are the most widely prescribed. Contraindications with these drugs. Systemic hypolipidemic drugs should not be used in patients with liver dysfunction. They do elevate liver enzymes, so we want to be careful with that. Bile acid sequestrants should not be used in patients with biliary obstruction, and statins are never, ever used in pregnant women. Drug interactions are listed on slide 22, and this was a short chapter, so that pretty much covers all that information. I hope you guys have a great week. Let me know if you have any questions, and I'll see you next week.